So let me introduce then Dr. Abbie Cawood, an honorary research fellow from the University of Southampton and head of scientific affairs at Nutricia. And so she's going to give us a really good practice example of managing malnutrition in the community.
Thank you, Leslie, for the invite to present today. And it's great, obviously, to follow on from Anne's presentation about the malnutrition pathway, because what I would like to share with you today is a best practice example of actually managing malnutrition in the community using all of the malnutrition pathway resources. So I just to set the scene, and you have heard this a couple of times today, but it never hurts to keep, as you say, Leslie, talking about malnutrition, raising awareness and saying things in the same way. So we know as malnutrition is common and costly, and this is really because of the consequences of malnutrition. For example, the increased complications, the GP visits, the hospital admissions. And we know it is really important to manage malnutrition appropriately, not only in hospital, but particularly in primary care, where we actually know the largest proportion of malnourished people reside. And both BayPen and NICE have shown that if you identify and manage malnutrition appropriately, you can make significant cost savings across the population. And as Anne has so beautifully just described in the previous presentation, there is a fantastic practical guide to managing adult malnutrition in the community, which is endorsed by a wide range of multi-professional bodies, including NICE. So I would really recommend everybody to go and look at the pathway and all of the resources that the panel have developed over the last 10 years. So I guess just to continue to set the scene a little, we heard from Trevor Smith this morning around poorer outcomes with malnutrition. A lot of that information was around our hospital inpatients, but we also know poorer outcomes for people. This is a small observational study here that you can see for individuals with poor intake and weight loss. And we clearly can see that those with poor intake and or weight loss, which are indicative of malnutrition, have reduced quality of life, increased falls, antibiotic needs, visits to hospital, and clinical outcomes like pressure ulcers. And this actually builds on other data that we have from the community, where researchers have looked at GP records from electronic patient records and compared malnourished patients to those that aren't malnourished, and found a significant increase in GP consultations and hospital admissions, which, as I'm sure everyone understands, obviously has massive consequences on the wider economy when more people are requiring more healthcare resources. And actually, we've also run one of the first randomized trials in the community as a team to look at the management of malnutrition across primary care, and specifically to look at how oral nutrition support can improve outcomes in older individuals who are malnourished and are in the community registered with their GP. And what I want to highlight from this slide is not only do we see significant increases in energy, weight, intake, and weight, if we manage those who are malnourished, both with dietary advice and oral nutritional supplements, but we also see these reductions in healthcare utilisation. So in this particular randomised trial of 308 free living older people, we saw reductions of 34% in GP and healthcare professional visits, 50% in emergency hospital admissions, and 62% in length of hospital stay in those individuals that were randomised to receive the dietary advice plus the oral nutritional supplements for a 12-week intervention period. And now if we move on to the best practice example of managing malnutrition, I guess what we really wanted to understand is the information from NICE based on systematic reviews and meta-analysis, the information from randomized trials that tell us if we manage malnutrition effectively, we can make a difference, not only for the patient, but also have an economic impact, we really wanted to understand if in practice, if we do this, does it also happen? So this is the best practice example. The primary aim of this project, it was a dietetically led local service evaluation. And it really was set up to assess the economic impact of implementing the malnutrition pathway in older adults in general practice, as well as doing this to assess the acceptability of their malnutrition management. And so I'll present this on behalf of the team that ran this piece of research. So if I just talk you through the methods initially before we get on to the results. So overall, in this service evaluation, there was 163 older adults over the age of 65 from 5 GP practices across Gloucestershire. And as I've already mentioned, malnutrition risk was managed according to the malnutrition pathway. And so what I mean by this, I guess, those that after a screening with MUST, the Malnutrition Universal Screening Tool, if they were found to be low risk, they just received routine clinical care. If they were found to be medium risk of malnutrition, so a MUST score of 1, they were observed and they were also given dietary advice from a dietitian. This involved using the sheets that have been designed by the Malnutrition Pathway panel alongside a telephone consultation from the dietitian running this service in Gloucestershire. And those individuals that were found to be high risk of malnutrition, so a MUST score of 2 or more, was the pathway was to treat. And these individuals, as per the malnutrition pathway, received the dietary advice, the same as the medium risk group, and they also received oral nutritional supplements and continued to be monitored by the dietitian over time. And you can see here, they were reviewed at 6 weeks, at 3 months, and at 6 months. And what we'll see in the results is actually how quickly we can make a difference by managing malnutrition effectively. And I think Anne just highlighted, to avoid unnecessary deterioration. And this is key about ensuring that we manage malnutrition, identify and manage it promptly. I think the other key thing from this service evaluation was at each review, the dietitian monitored goals, checked weight, checked the Malnutrition Universal Screening Tool, and assessed compliance and satisfaction to the regime in which they had been given. So if I now just talk you through how we looked at healthcare utilisation. So we did this by doing a retrospective review of healthcare use using the electronic patient records that were held at the GP surgeries. And this was done by looking at the 6-month period for each patient before the implementation of the malnutrition pathway had occurred at these practices, and comparing that to the 6 months after the implementation of the malnutrition pathway. And the sorts of healthcare use that we collected and looked at was hospital admissions, length of hospital stay, number of GP appointments, total number of healthcare professional visits. That included GP visits, nurse visits, and even visits to a hospital doctor, and the number and type of antibiotic prescriptions. And by having this information, we were able to undertake a very simple cost analysis using published costs, and then compare this on a per patient basis, looking at the 2 periods. And now I think what was really key with this project was we looked at both sides of the scales, and you can see this at the bottom of the slide. So on the left were the costs to implement the malnutrition pathway. So what did it cost? The dietitian's time. And that was the time for the dietitian to screen the individuals with the Malnutrition Universal Screening Tool and do those reviews and follow-ups that we looked at on the previous slide. It also includes the cost of the GP time to initiate the prescription. And this obviously was only applicable in the high-risk individuals that then were prescribed oral nutritional supplements. And again, in those individuals who received oral nutritional supplements, the full cost of that prescription was also put into the simple cost analysis. So that's one side of the scales. And on the other side of the scales are the savings we make by seeing the reductions in the healthcare utilisation by effectively and appropriately managing malnutrition in this cohort of individuals. So what did we see in this service evaluation? As I mentioned, there was 163 patients, just over half were female, and the average age was actually 80 years. There was a real wide range of primary diagnosis, as you would expect to see in primary care. One of the highest diagnoses was actually respiratory within this cohort of individuals. And on average, the prescription length for those that were in the high risk of malnutrition group was 14 weeks. Now, hopefully you remember we looked at healthcare utilisation and the change from 6 months before we implemented the pathway to 6 months afterwards. And you can see now in this table below the sorts of differences that we saw. So if we look at those that are at risk of malnutrition, so if they were at medium risk and high risk, you can see the reductions there in healthcare utilisation, of which the majority were significant. They were all significant apart from the total healthcare professional visits, with really good reductions in healthcare utilisation. What you can also see in this table is those in the high risk group, those that received dietary advice plus the addition of oral nutritional supplements, had even greater reductions in healthcare utilisation. And these were all significant reductions in the high risk group. So this really showed us that by practically implementing the malnutrition pathway, we were able to see clinically and statistically significant reductions in healthcare use, which I think was amazing. And, it was a very exciting finding, one which obviously we'd hoped to see from all of the information that's in the public domain about the appropriate management of malnutrition. Just to highlight, there were not these same reductions in just the medium in the medium risk group, which I'm not presenting today. So as I mentioned, we also did a really simple cost analysis, and this is some of the figures here on the slide now. So we were able to model up the costs, as I mentioned, to look at a per patient saving. And these were done if we look at the reductions in hospital stay, healthcare professional visits, the antibiotic use, balancing it with the cost of the dietetic time, the GP time, and the supplements for those at high risk. When we look at those individuals at risk of malnutrition, we saw per patient reductions of nearly £400 per patient. And if we look at those at high risk only, we were nearly at £1,000 per patient if we identified and managed malnutrition according to the malnutrition pathway. And you can see here, we also did a budget impact analysis to really scale this up to see what those savings may equate to if we look at it per 100,000 population. So similar to what NICE and BAPEN have done in the past. And these savings are also shown on the slide. So these are savings if we consider managing malnutrition in older people who are at risk of malnutrition living in the community. So these net savings are from, as I say, that reduced healthcare resource. So I hope you can see that there are real potential cost savings to managing patients at risk of malnutrition using the malnutrition pathway. And I think what's really key is these savings actually are achieved over quite a short period of time. So this was over that 6-month period. And if you remember, the length of time on oral nutritional supplements for those at high risk was around 14 weeks. So we also looked at compliance and satisfaction to the oral nutrition support that individuals received in this service evaluation, and the results are amazing. So in terms of dietary advice, 81% of the individuals found it easy or very easy to follow. As I say, they received the sheet that is part of the malnutrition pathway resources. 97% of patients were satisfied and very satisfied with the dietary advice they received. And those that received oral nutritional supplements as well as the dietary advice, 96% were satisfied and very satisfied, and 92% found them easy and very easy to take. And overall, the dietitian looked at compliance to the oral nutritional supplement prescription and found they were taking around 90% of what they were prescribed to take. So I guess the key here is you see the benefits of the oral nutrition support when the individuals actually are able to comply with both the dietary advice and potentially the addition of oral nutritional supplements. So I guess in conclusion, what I wanted to share today was that this service evaluation really demonstrates practically the positive impact of following the malnutrition pathway for patients at risk of malnutrition in primary care over this relatively short period of time. It highlights the importance of screening and appropriate management, which includes oral nutrition support and very much reviewing the patients against the goals. And that's really key part of the pathway resources. It highlights the greatest impact for both the patient and the wider healthcare economy is in the management of those at high risk of malnutrition. And finally, overall, the costs associated with managing malnutrition were more than offset by the savings. And I just wanted to take the opportunity also to thank all the collaborators on this project. And you can see there the publication that we have on this particular implementation of the malnutrition pathway, and also my wider colleagues for the randomized trial that we also have undertaken in general practice. And finally, I guess just to give it another plug, following on from Trevor Smith's presentation this morning, I also sit on the malnutrition action group of BAPEN, and just to highlight the amazing activities, I guess, are going on part this week as part of UK Malnutrition Awareness Week. And one of those is our nutrition screening portal. It's now open and live. You can sign up, and it would be great to get a more up-to-date picture of the real scale of the issue of malnutrition, and also our nutrition support that we use to manage these individuals. The survey is open until the 31st of October, and you can see there the web address if you would like to take part. It's really quick and easy to do. All the calculations are done for you behind the scenes. So thank you for inviting me to present today. I hope you enjoy the rest of UK Malnutrition Awareness Week this week. And as I say, please also take part in this survey as part of BAPEN. So thank you.
Thanks, Abbie. Very interesting. Always interesting to see how tools have been used in clinical practice, isn't it?
Yeah.
And especially when the outcome is potential cost savings to the wider health economy. So it has to be good. Yeah.
No, I think it's always nice to, continue to build the evidence base, doing lots of different types of projects as well. We have systematic reviews, meta-analyses, we have randomized trials. And sometimes like this, it's just really lovely to see that when you do it in practice, in your own clinical practice, you see all of those benefits that we see from clinical trials. So yeah, and I think Anne said, where malnutrition is mainly treatable, if we embed these sorts of pathways early in care, we can really make a difference, not only for the patients and their outcomes, but also, as you say, Leslie, for the wider economy, which, is hot on the agenda these days as well.
Certainly is. Well, thank you very much for your time.
Thank you, Leslie.